or not, I do actually spinal cord mapping, especially for redo surgeries where we have a different space available. The spinal cord has scar tissue, and it would be difficult for to use T-wave, especially if the patient already is presenting with deficits. So I do spinal cord mapping in those patients. Anyways, we'll discuss that talk during the course. So my name is Tariq Imtiaz. I'm a consultant physician working as a. Can you hear me?
Yes, we can hear you, but if you
Hello?
talk too fast, then we hear an echo, but we can hear you.
Can you share the screen whole page?
Dr. Zileli, I'm actually using my iPad. 1 second. Let's see if I can. Are you seeing all the pages or only my page that I'm showing?
No, we see also the background and other slides.
But it's,
probably it's the iPad issue, Dr. Zileli. Probably.
it's okay, but but it's okay because we see your main slide, so you can go on. Because if you change it on the iPad, in my experience, then some things might go the wrong way. So you can proceed now.
I work as a physician, as a neurophysiologist, and we do in the operating room where our protocols are that the physician need to be present in the room as mandated by Ministry of Health in Saudi Arabia. And we are also the accredited facility by ABRET USA. So, for the last 10 years, so we are the only institution outside of the US to be accredited for IOM. I have no disclosures. So the objectives of this talk, first, I'm assuming most of the attendees are surgeons. So we will revisit some of the modalities that have been used for spinal deformity IOM setup. And then I'll be sharing with you my data and the evidences. Talk about surgeons, and I'm hoping that after the end of my talk, more surgeons would be convinced to use monitoring, of course, when they have the availability of trained staff. And then if I have time, I'll show you some cases with data changes also. Now, the literature about the use of IOM in deformity surgeries and the use is based on, number one, patient safety. Safety is an important aspect. Dr. talked about it, or Professor Aleph talked about it. Then, of course, ethical concerns about the whole useful service. Dr. Zileli asked a very good question about, the use of neuromonitoring competent or, the not properly trained technologists. But if you have trained technologists, there is good reason to use neuromonitoring. Then, of course, there are medical legal concerns of using or not using neuromonitoring, whether the deficits were preventable or preventable. So this is another aspect where state comes in, and especially in states or in countries where the medical legal laws are strict, there is a use neuromonitoring also. And peer recognition is like these conferences, which is educating people about neurophysiology or intraoperative monitoring. And then we discuss the availability of trained. I will briefly discuss the issue which was briefly discussed by Professor Aleph in the first talk, is the cost of disability. I'll get to the next slide. I just added these blue lines, if you're seeing in blue, where the lack of class 1 evidence is probably one of the reasons a lot of surgeons use monitoring. If you don't use monitoring, we will not be able to have that class 1 data that we are talking about. So, when there is enough evidence to use monitoring, I think is that people should use monitoring. I'll go to the cost of disability cost. In spinal cord injury, this is from the spinalcord.com. In 2023, they talk about having tetraplegia, and the year cost in the US was $769,000. So assuming, that quadriplegia was preventable for a cervical tumor, that's an alarmingly high cost on the society. And then even if it's only paraplegia, I would say just relevant to quadriplegia, the first year cost was $518,000, and in subsequent years the cost goes to for paraplegia about $69,000 per. Monitoring probably even in the Western world would not be that the cost that would come back to the society or to the patient if it sustains paraplegia or quadriplegia during the surgery. So there is a financial reason also to use neurophysiological monitoring. I'll go to the slide. We also spoke about training the underprivileged countries. This is the UN report on disability that came out a few years ago, and they talked about much higher developing world, probably because the infrastructure available in developing world, the infrastructure related to medical facilities, the post-op, rehab, financial and psychological support. So let's go very developing world to actually train more people and be able to do intraoperative neuromonitoring for deformity, other surgeries also. Our center, as I mentioned, is an accredited center. We have been training technologists for all those years, more than 10 years now, and my working all around the US and Canada, UK. I mean, people are welcome to join us if they are looking for training. So disability cost developing world is, it is much higher, as UN report talks about. Now, this is another report from the Institute of Medicine in US that came out in 2013, which says patients must be a part of policy. Now, this is talking about state policy. That is, the state must ensure that patient has maximum whatever the facilities available to its functions or related to patients' matters. So intraoperative monitoring is, of course, one patient safety. Professor Francesco, in his last talk, spoke about that. Intraoperative monitoring was providing was more the patient outcomes were better in with use of intraoperative monitoring. But there is not just physiology community or surgeons are talking about or promoting neurophysiology. In fact, the patient safety is an important issue right now, and intraoperative monitoring is a very that helps patients. Now, American Academy of Neurology came out in 2012, and they advised or suggested that the use of somatosensory evoked potentials and fast cranial motor evoked potentials should be used in intraoperative monitoring for spinal surgeries, and hence I thought to place this slide as a relevant slide because I'm talking about for deformity surgeries. Now, spinal deformity, I'm not going into the surgical details as most of the surgeons are amongst the audience, but there are important types, kyphosis and lordosis. So from this slide onwards, my data or what I'm talking about is precisely based on setup and the data we have on scoliosis, but you can assume that the same methodology can be adopted for kyphosis. For example, kyphosis or lordosis in the craniocervical or the lumbar areas. So what are the events that actually cause deficits or changes during spinal deformity surgery? If I highlight one event, that will be ischemia. And now, ischemia is caused by hypertension and global ischemia, which is obviously related to hypotension. A lot of surgeons in scoliosis, especially if some major scoliosis, they opt hypotensive exposures. And I've seen in my experience that patients with hypotensive exposure actually going from Cobb angles greater than 90 degrees. Those patients, if you sustain an injury in a medial breach, those patients would have deficits because you have been exposing for, you can say, 1 hour to 2 hour due exposure for setup. So that patient may cause an abrupt change in MEPs if there is a medial breach to, and that patient may suffer long-term sequelae as well. So our setup in our hospital, we don't go for hypotensive exposures. We like to expose, even in scoliosis cases, normotensive exposures to avoid, just in case if there is an injury down the line during surgery, we can prevent deficits. Then, of course, so if you follow my slide here, if there is a bleeding event, if there is localized ischemia, can IOM help? Yes, of course it can help. Then, of course, during surgical maneuvers, for example, compression or stretching, during vertebral column sections or hemilaminations, during major scoliosis surgeries, can IOM help? If there is a change in data, is data eligible? These are the questions surgeons ask. So can IOM answer these questions? Yes. Now, as you can see in the middle of this slide, I'm giving you an alarm with a red circle on it. We have a very limited time frame to prevent connection block. Now, the time frame is from 0 minutes to 30 minutes, depending on nature of injury, the spinal cord is surgical maneuvers. If there is a major breach, time actually, and you have caused damage, but we can immediately notify to the surgeon, and there is still time for spinal cord to regain. So the answer of all these questions is yes, IOM can help the surgeons. These are some of the basic questions the surgeons ask from neurophysiology. So we were discussing it before my computer went down, that surgeons want to know, what exactly, what these are the questions I'm asking. Have I injured the spinal cord? Is the change, is it reversible? What should I do to reverse this? So I'm answering these questions with my next few slides. This is a very important slide for neurophysiologists who are watching from around the world. This is my template that I designed myself for scoliosis cases. As you can see, you have numbers written on it. The extreme left of the paper, there is numbers, spinal column numbers, T1, T2, 3, 4, till S1 or iliac screws. And then I have time written on it. And then if you can see, these are times that when the surgeon is making a pedicle hole, or the time where the surgeon places the screw. And then I have a check mark, because my team, or if I'm around, or if my technology around, they would, after the screw, they would do the transcranial motor evoked potentials and bilateral lower limb SSCPs, and they would make sure that the data is intact, no change from baselines, and they would communicate to the surgeon. So hence, a good communication with a surgeon, following the surgeon each step of the way, is the recipe for good results in deformity, especially in scoliosis surgeries. And my team follows this. And just in case if there is a change in data, we know that which screw had this. There is no point missing doing the transfer potentials for 3 screws and then doing it 3 screws later, only to know that you have a change in data. That doesn't really help, because we don't know now which screw caused this change. So it is important that there is good communication between the technologist and the surgeon, or the physician and the surgeon. My team takes a record of these screws, and it goes with the medical record in our system. Now, we also talked about the IOM modalities in spinal deformity surgeries. If you see on the left and right arrows, we're talking about somatosensory potentials and transcranial motor evoked potentials. These are the 2 pivots that the intraoperative monitoring relies on. And, as we discussed it already, in sensories, you stimulate in the pericord in the central nervous system, and in transcranial motor evoked potentials, the nervous system or the scalp using scalp electrodes. And the idea is that you record from the muscles as the endpoint of the peripheral nervous system. So both these machines are a must during spinal deformity, or in any IOM setup, even in brain surgeries, and use these nerves for SSCPs and in MEPs. I also EMGs, it was also discussed in the previous talk about relevant muscles, involvement of relevant muscles, and including those muscles in our system in our protocol for the IOM. Then I do spinal cord mapping in tumor surgeries very regularly, especially because we are a large center. We receive a lot of E2 patients and referral from remote areas, and those have already been operated upon. And I feel spinal cord mapping is imperative in achieving good results in those surgeries. Then I do EEG as a standard in all my patients, primarily because we are helping as a team with anesthesia, indicating them for the depth of anesthesia, because it helps in achieving our data and data acquisition. But also I do EEG because in somatosensory evoked potentials, it takes time to average those signals. If you have a good EEG, you can communicate to the anesthesiologist about the depth of anesthesia, and if there is a patient light or deep, you can communicate to anesthesia. They can help you with the depth of anesthesia, and they can change their dosages of TIVA and get somatosensory work potentials in very few averages. So in setup, we get somatosensory work potentials in like 5 or 6 averages. That's good enough for us to get a reliable waveform. And of course, there's spinal motor work potentials as well. I don't do D-waves and BCRs in deformity surgery, primarily because I feel that SCPs and TCMEPs are good enough information for surgeons. In some patients, it may be useful if we lose data, and especially if the access to epidural or the access to subdural electrode where we can do D-waves is available. But as a routine, we do D-waves and BCRs in spinal surgeries. Now, this is my take-home slide for anybody watching, especially the younger neurophysiologists or the surgeons who want to know exactly what is data to them. This is our own data of 800 plus scoliosis surgeries. As you can see, 76% of these patients have no change at all in our setup. Now, the remaining 24, not all telling you that the patient has been paralyzed. No. If you read the data, there is a major chunk with a blue color. It says TCMAP greater than 50%. 13% of those patients presented with TCMAP change, which was greater than 50%. Then we have SSEP. Interestingly, we spoke about multimodality monitoring. So far in scoliosis cases, I have not seen a single patient with only SSEP loss. So I have the most alarming patients are those patients where we have where we I hear background. So the red alarm patients are the patients on the extreme right, the 4% where TMEPs plus SSEPs both changing. They were 4% of the data. And these are mostly those patients where Cobb angles were greater than 90 and 100 degrees. Then anesthesia-related changes where mistakenly anesthesia gave a neuromuscular blockade or a bolus dose was given, or they were unable to provide the transfusion on timely. So there were 3% of those patients, they caused the data change. We talked about EMG. Now, EMG, that really translates into a post-operative deficit. We need to correlate that EMG change with the TCM change. And in our scoliosis study, we found that only 2% of those patients where we saw EMG that actually led to TCMEP change. So the take-home message is that the SSP and TCMEP, if they change both, if they drop both, these are the real red alarms, and the surgeons must stop. But the changes in the TCMEPs, which is about 13% of our data of 800 plus scoliosis, it is not an alarm. It is just a caution where we then look for mean arterial pressure and the changes mostly. Now, this is a very important paper that actually came out a couple of years ago, and this is another take-home message for surgeons that really, when there is an alarm that is being raised by neurophysiologists, when you have immediate interventions, the patient's recovery were 80%. Comparing it, when the alarm was raised to the surgeon, but no surgical intervention was performed, the recovery is only 26%. So, there is significant difference when the intervention, for example, the neurophysiologist is asking for a removal of a screw, or a change in the mean arterial pressure. And if it's not listened to, then there is the recovery significantly drops. And then there is no alarm raised with no interventions. There are 14% of those patients who didn't really didn't really benefit from IOM. Overall, if you have good neurophysiology monitoring, complete or partial recovery on discharge was 53%, comparing it to 21%. So, this is the significant study that talks about surgical interventions created by neurologists improves patient outcome. Now, I'm going to briefly go over these slides. We have been discussed already in detail by earlier 2 speakers. We know that somatosensory potential ascending signals. We know we state in the periphery for the sensories. and we can record in the peripheral nervous system, or we mostly record in the central nervous system. Now, what happens here is, for example, median nerve or ulnar nerve in the upper limb, and we record from the scalp. The significance criteria is the latency. What time the signal takes from the arm to the scalp. Normally, in normal adult, is about 20 milliseconds. And then in the lower limb, from posterior tibial ankle to the scalp is about 37 milliseconds. So we note that. Then if there is a change during latency, which is more than 10%, we communicate it to the surgeon. For example, during surgery, this 20% changes, 20 millisecond changes to 23, 24 minutes in one lower limb. We communicate it to the surgeon, and that's how we decide, whether there is a significant change or not. SSCPs. Then we have TCMEPs. If you see on the now in TCMEPs, the stimulation is in the scalp. Through the scalp, we want the gray matter to be stimulated, and then we start from the distance. Here on the right of the screen, you see left body responses, where the top one is the left upper limb, and the remaining 5 muscles are the lower limb. And similarly, on the right side, extreme right, we have the top one as the upper limb muscle, and then muscles are the lower limb muscles. So in that way, at the start of the surgery, we record these as baselines, and during the surgery, we see if there is a change, and we communicate the change to the surgeons. Now, this is G change, as we discussed. On the left of your screen, you're seeing a normal EMG with not really much activity going on. But when you come to the right side of the screen, you see the extreme right discharges, which is significant. Those discharges need to be communicated to the surgeon, especially if it's in the cervical areas there, or in the lumbar area, or in quad actina. And we use shoulder to settle them down if this persists, and we ask the surgeons to give a momentary pause until these EMG activity settles down. Now, as I showed you in my previous slide, there is a 2% chance that the activity continues. They may lead to a TCMEP drop on that specific muscle, which may cause a post-operative deficit. Now, this is a significant criteria we follow, as I discussed, for SSCPs. 50% drop in the amplitude, which is the size of the wave, or 10% drop, which is the time it takes from point of stimulation to point. Then I just showed you in the previous slide as the type of discharges. A normal burst or here and there infrequent discharges, we still communicate to the surgeon, but not really get alarmed. Now in TCMEPs, in my protocol has been to do in spinal deformity. In brain, I use a different protocol, but in spinal deformity case, we go for all or none responses. Even if we have a smallish response, distal to the location of surgery, let the surgeons continue correction, but we still communicate if there is a drop in amplitude, or if there is a change in the intensity which we're using for the position of my data. Now, these are samples. So I'm showing you the triggered EMG, where you're seeing on the top left, there's a normal, no breach happening, spinal canal is clear, so no changes. We can do the screw stimulation test, which is also called triggered EMG, which is an EMG-based test, but now this is a stimulation-based test, in comparing it to free-run EMG, where there is no stimulation going on. And then we look for breaches. If there is a minor breach laterally, let me warn the surgeons that lateral breaches, especially in thoracic area, are not picked up by IOM team, because we're not monitoring all the thoracic nerves, all those levels, because our system doesn't know it. If we monitor 12 thoracic nerves, it will be too much data to incorporate in our system. So generally, this is a good test for medial breaches in the thoracic region. If the screw has gone into medially, touching the cord or hitting the cord, see a change on the TMEPs or maybe MEPs. And generally, for screw stimulation, a good screw region is higher than 10 milliamperes if it produces a response high milliamperes. Relevant muscle, we consider it as a good screw. And in thoracic level, there is a gray area. Generally, we consider 8 milliamperes plus a good response. In our setup, not all are a big fan of this triggered EMG test because of its extremely overt, too much sensitive test. Sometimes even a get a response. So we always communicate to the surgeon whether he felt good purchase while placing the screws. And if he felt good purchase and there are no changes in the TCMEPs, we screws if the levels of the intensity levels are 6, 7, 8 milliamperes. Below 6 milliamperes, definitely in thoracic areas, we ask surgeons to reposition the screws. Similarly in lumbar levels. Now, this is just an example to show you guys how change is picked. We talked about a good neurophysiologist back in a couple of, in previous 2 slides. Here I have given examples of screws, and I've given you data. The top right is the left and right TCMEPs, and on the right 2 bottom screens, you see left and right TCMEP, same TCMEPs. Now, if you can see this on the bottom right, we are seeing a drop in the amplitude in all the muscles, including the upper limb muscles. If you see the top muscle is the upper muscle, and on the left side and on the right side. So it looks like a global drop. So this is not a change caused by any of the screws. So if you're creating this sort of an alarm to the surgeon, screws is not only trust, but you are creating false positives, which is not warranted in good setups. So this is a change that is due to hypotension and easily communicated here, and surgeon need not to be bothered by this. Now, this is a true surgical data change where you can see that there is a significant VCR, there is significant decompression as well on the cord, and you can see the right side top, we have left MEPs, then the right MEPs, and you see the bottom 2 pictures. We're seeing upper limb is intact, but the lower limbs are down. So this is a true change, and in that way, we're able to communicate to the surgeon that left side, as we are seeing significant drop of approximately reaching 100% drop, and on the right side, 50% drop, and that way we communicate to the surgeon and decide what is the next best step to do. Mostly, it is the reversal of the procedure, of its derotation, reverse, or even suggest at times fusion in situ. Now, this is another important point. We talked in my slide, I spoke to you about 2% positioning change that we have noticed, especially in the cervical levels. Now, always we do pre-position data in cervical fractures or in fractures or in unstable spines. The surgeon is putting as a posterior setup, or as a posterior approach or prone approach. This is the patient I'm showing to you. During positioning, we lost right-sided MEPs. We got a pre-position data, but during positioning, we lost the right-sided MEPs. Left-sided MEPs stayed intact, and as you can see that the bottom on the left side, there are no waves, which means so we communicated to the surgeon, and post-op MRI was showing there was a right-sided infarct at the level of C5, C6. So in that way, I always recommend to my team to do pre-positioning supine data, especially in significant deformity patients or in fractured patients or unstable spines. Now, there is another where I'm showing it to you that on the left side, top left, you're seeing a significant burst of discharges, and on the same side, seeing the same muscles, MEPs. But if this discharge continues, you see the bottom picture where in the smaller red arrow shows to you that this muscle is dropping MEPs, and in that we're able to tell the surgeon that yes, this is happening, and this is a preventable aspect, and we can communicate to the surgeon whether he takes a momentary pause or irrigation. Sometimes we have even used steroids, or in most cases, just pausing for a little bit or increasing the mean arterial pressure restore data. Now, as you know, I had to, part of the reason actually, I think my computer broke down because somebody was asking about chord mapping, and I had to include these slides into my last 2 slides. As you can see, this is a 16-year-old girl presented to us with, on the top left, you're seeing an abscess or infection developing in the middle of the thoracic spine. And this patient was operated 10 years ago for a road traffic accident. The screw moved gradually and the patient developed severe kyphosis. And the screw is now sitting in the middle of the cord. I mean, there is no way our TCMEPs or SSAPs are going to tell surgeon where to proceed or where to intervene to remove this screw. Luckily for us, the screw caused granulation tissue around it. So we were able to map the screw all around in 360, and we were able to tell the surgeon where we were not able to get responses to proceed from that area and open the port from there. And luckily that granulation tissue saved us. And I'll show you how the spinal cord looks like. This is how we stimulated the cord all around in 360 degrees in a single pulse technique, and we were able to recruit signals. And where we not recruit signal, we actually from there. We were doing somatosensitive potentials and motor review potentials along with that. So this is my last slide. Strongly recommend if you have time. These are the papers that I wrote on spinal deformity and the use of intraoperative monitoring. And Professor Zileli was kind enough to provide me with the opportunity. Both these books are published recently in the last 1 to 2 years, and both have detail on intraoperative neurophysiology and deformity correction surgeries. Thank you very much.
Thank you, Tariq. It was a very nice, informative talk. There are some questions from the audience. One is that, is monitoring advisable for anterior spine surgeries? Are you doing some monitoring with an anterior spine surgery, like cervical anterior surgery or thoracolumbar anterior surgery?
Yes. So in our, I'm not sure my video is showing up or not. Yes, in our practice, for example, I will start with the thoracic deformities. We do thoracic anterior release, where the major vessels are in play. So we monitor those patients with both somatosensory and TCMEPs. In cervical spine patients, especially redo patients or obese patients, because we're busy, we have much of patient overload for brain tumors, and most of my practice is on brain tumor. Generally, we don't monitor ACDF patients, but if there is a redo, can you hear me?
Yes.
Yeah. If there is a redo procedure, or when there is recurrent laryngeal nerve or the carotids are in play and the surgeons are worried about carotid, retraction, they use monitoring. Or if they are doing multiple corpectomies on the cervical level, especially TB spine, those patients we do spinal intraoperative monitoring for those cervical cases as well.
All right.
But not routine ACD. Don't monitor routine ACD.
Because it's not necessary, because they are low-risk surgeries for neurologic dysfunction. What about
that is true. Less than 1%.
Sensitivity to predict proximal leg weakness, L2 and L3 myotomes in deformity surgery? What do you think about this?
The sensitivity to predict weakness. Now, you see, the important part here is to
upper lumbar roots.
So the question is upper lumbar surgery and whether we're able to identify changes in the proximal distal limb muscles or the lower limb muscles. So the important point, I normally teach my techs or my team or even with my interns, we use all relevant muscles. For example, the dorsiflexion is a very important function that we want to keep in our surgeries. We don't rely only on tibialis anterior response. I always include extensor hallucis longus response, because I've seen that one muscle does not give you enough information about the sanctity of that particular function. So yes, we can include more muscles. Generally, as you've seen my slides, I have at least 5 muscles from the lower limb in deformity surgeries. Yes, we can predict whether there is a change happening in the L3, L4 for the quadriceps, or for L4, 5 in the dorsiflexion muscles.
Another question is that, in your experience, how long does it take for the MEP to return back?
Very good question. Very good question, Professor Zileli. That's an excellent question. In our patients, as you've seen the data, 50% change is about 13% of the time that we're seeing. Now, 100% change, unilateral 100% change invariably happens when there is a significant medial breach. And our surgeons are, we have good team rapport and good team setup that they tell us. so we're in a way lucky. Now, if we have a sudden drop in MEPs, and that drop reaches 100% unilaterally, no change in SSEPs, the maximum I have waited is 90 minutes. But most patients, we immediately increase the mean arterial pressure. And sometimes we even have given steroids, 4 or 8 milligram of dexamethasone as a bolus dose. And generally, those patients come back, the MEPs come back within few minutes. But if there is maximum, as I told you, the maximum I waited is 90 minutes. But out of those SSEP and MEP 4% patients that I showed to you, generally, if we have a drop that does not come back within this time frame, we don't wait anymore. We stage the surgery, we come back. And if there is only MEP drop, but SSEPs are intact, most of our patients come back within a few days, and we bring the patient back in a week.
There is one question, but what do you say about this? What is your opinion on using these semi-autonomous surgeon-directed devices on these cases?
Yeah, so see, I mean, the surgeon-directed devices have limitations. I will go into technical detail. Probably the audience, if there are more surgeons, they would probably not appreciate, because some of the devices that I'm familiar with, they don't stimulate transcranial motor potential, so meaning that you're stimulating the brain and you're seeing bilateral responses coming in both limbs. Not really sure that you stimulated the right brain or the left brain. Then all these devices have limitations of channels. If you are doing a major surgery like major scoliosis, 100-degree, 140, 130-degree scoliosis, you need to include more muscles to have enough information to provide to the surgeon so he completes the surgery reliably. These surgeon-directed devices have very limited channels. You cannot have more than, I think, 3 to 4 channels, so bilaterally. So, I mean, you have limitation of information. Then also there is a drawback that, we cannot do EEGs in those machines or SSEPs in all 4 limbs because the limitation. I think the data would be not comprehensive for you. And I mean, you can maybe monitor one nerve, but not as a complete central nervous system and peripheral nervous system monitoring. So I think I would not advise surgeons to use, surgeon-directed devices and rely on them solely.
Yeah. What about, do you recommend using D-waves in deformity correction surgeries?
Generally, as a practice, no, in deformity correction surgeries, because, D-waves need to be, either we need to have some access, especially in the epidural space or subdural space. There are methods of doing D-waves from the paraspinal muscles, but, I would probably do more MEPs and more focus on MEPs. But generally, for spinal deformity, no, we don't monitor D-waves or BCRs.
Thank you. Dr. Kubilay Varlı wanted to ask something, I think. Are you still there?
If I have, maybe if Francisco is here, Dr. Zileli, as a surgeon, I would like to know the surgeon's perspective on spinal tumors. You see, we talked about D-waves and we talked about muscle MEPs, but some of the patients that we receive are redo patients. They have been transferred from remote areas, previously operated, already coming with McCormick grade 3 and 4. So my question, Francisco already showed to us that 40 to 44% of the time he was able to get D-waves. So meaning 60% of the time he was not able to get D-waves. Now those D-waves also are smaller in amplitude. So do we follow the same criteria? I don't know whether Francisco is there. So in my practice, this D-wave is overemphasized if you have a patient with McCormick grade 3 and 4. Yes, if you have a patient with McCormick grade 1, and you get excellent D-waves, and you can reliably communicate to the surgeon if there is a change. But redo patients with scar tissues or astrocytomas in the spinal cord, where the spinal cord is already taken or eaten up part of the cord, it becomes very difficult. So I mean, we need to be very careful when we're monitoring for spinal cord tumor surgeries, especially if they are redo surgeries.
Yeah. Elif, do you want to add something to what Tariq has said?
It was an excellent talk. Thank you very much. In many cases, an experience.
Okay.
Yeah, Professor Arif, I can hear you.
Yes.
I didn't hear the full question.
No, there was no question. Just
There was no
comment.
contribution and question. Thank you.
Thank you.
Yeah, thank you very much. Thank you very much for you also. You highlighted some of the very important aspects of the basics of neurophysiology, and it helped. I think it was a very useful talk.
Thank you very much.
Unfortunately, Wilco must leave us earlier. He had an emergency case, and I will stop the meeting here because there is no more questions. I thank all the speakers for their very nice talks and great contributions. This is still a discussable topic, intraoperative monitoring, but it has certain indications and certain great applications. Thank you for being with us. I thank all the participants also.
Thank you, Professor Zileli, for inviting us. It's a pleasure.
Goodbye.
Bye-bye.
Goodbye.